some guidelines, and I will go through just a few of them and clinical practice recommendation, and I'll try to summarize and to conclude at least something what is reasonable. Well, during the history, we completely changed our attitude to the beauty, to the term of beauty, and also to the term of normal weight. So previously we thought that this is the term and this is the appropriate beauty. Right now we have completely different situation, and it seems that we changed the positions. But there is no doubt that obesity is a chronic disease with a complex etiology. I will not go into details regarding pathophysiology of type 2 diabetes and obesity and insulin resistance, but, because it would last forever. But we know that it's a complex etiology of obesity. So also we cannot have only one key to resolve all problems in pathophysiology of obesity. On the other side, obesity is associated with many complications. You know, those complications can be metabolic, primary, but also that can be the mechanical, physical, psychological, but also cardiovascular disease and pulmonary disease and many others. But the main problem is here, because people who are obese, the life expectancy for those people are significantly reduced. And if people have, for example, BMI between 30 and 35, the life expectancy for those people will be reduced by up to 4 years. And for somebody who has obesity of third grade of obesity, so BMI more than 40, the life expectancy will be reduced up to 10 years. So obesity is the second biggest killer and the second leading cause of preventable death. This is the situation in the world. Approximately 40% of all people worldwide are overweight or obese, and almost more than 13% of them are obese in worldwide. In Europe, we are even worse. 52% of adult people are overweight or obese, and 60% are obese between 60.3 and 60.8. And can you imagine what about Croatia? What is your image of Croatia regarding obesity? Well, I will share with you our results. Can you imagine we are winner in the Europe? So in Europe, we are on the first place. Can you imagine that? We are on the first place regarding overweight and obesity, and we are sharing that first place with Malta. And in Croatia, we have 64, almost 65% of overweight or obese people, and 23% of them are obese. That's the reason why I'm trying to hide my stomach as well, and I'm trying to do hardly, but I cannot succeed. So obesity right now is recognized as a disease and health issue, and you can see it here. The majority of different associations recognize obesity as a disease. When we talk about the obesity management guidelines, there are many different guidelines from many different associations and professional organizations, and you can see it here. But those guidelines are focused on clinical management of obesity, pharmacological management of obesity, obesity in people with diabetes, and obesity in people with cardiovascular disease. And we will briefly focus on several of them, primarily on Canadian, UAE, and also ADA and EASD guidelines. And we know when we are defining obesity, we are usually using BMI. And we know that BMI can underestimate and overestimate the real body composition. Because if you have some sportsmen, you will have underestimation of BMI and the value of BMI. And also, we know that some guidelines also include cardiovascular disease risk. And you can see it here, majority of guidelines and majority of professional organization will argue about just BMI. And BMI in Asian population, we know that it's completely different than in a Caucasian population or other population. But just few of them will take into consideration waist circumference, and very few of them will take into consideration complications. So this is something what we have to consider when we talk about obesity and the treatment of obesity. I will briefly show you the Canadian guidelines, and can you imagine that almost 15 years there is no new guidelines, there is no update of the clinical practical guidelines in obesity in Canada. On the other side, we know we can argue about increased prevalence of obesity, not just in Canada, but worldwide. Also, we know that healthcare professionals do not feel equipped to manage obesity, because our curriculum on the university is not focused neither on obesity, neither on other chronic diseases. And also, lack of recognition of obesity as a chronic disease. And between last two guidelines, before, obesity was defined only by BMI, about 30 kilograms per meter square meter. And now, obesity is a complex disease. So before it was a state, right now it's a disease. Even WHO defined that obesity is a chronic disease with the diagnosis code. And we know that right now we are focusing on patient-centric care, moving from the just sentence, eat less and move more. Right now, we know that it's not like that anymore. On the other side, reducing weight bias in obesity management in Canada, you can see it here, that also new guidelines are focusing on that healthcare providers should avoid judgmental words, images when working with people with obesity. Like we talk about people with diabetes. Right now, we are talking about people with obesity, not obese patients or patients with obesity, but people with obesity on the other side. And Canadian guidelines have 5A. One, ask for permission. Two, assess their story. It's not just eat less and move more. You have to exclude the other pathophysiological mechanisms of obesity. What about thyroid gland? What about adrenal gland? And also, we have to find a solution regarding mechanistic, metabolic, mental, and also social milieu. Number 3, advice. It's not just advice in dietary approach. And we heard about dietary approach and also medical nutrition therapy, what is extremely important in the treatment of obesity. We heard about physical activity in the previous talk. But also, right now we have, beside medical nutrition therapy and physical activity, we have a possibility of pharmacotherapy and also bariatric or metabolic surgery. Fourth, agree on goals. So we have to have action plan with our patients, because it's our fight against their obesity. And also redefine success. And fifth, assist with drivers on weight gain. So this 5A framework was unique worldwide. And Canadian Association for Obesity, they are pretty good in consideration regarding the guidelines and also recommendations. On the other side, also, they recommend to focus on other risk factors for cardiovascular disease, blood pressure, lipid profile, glycemia, and other risk factors for cardiovascular disease, and particularly also at non-alcoholic fatty liver disease as well. So I already mentioned that medical nutrition therapy in obesity treatment is not just about diet. Because when we talk about diet, we can talk about diet. Somebody can see some recommendation in newspapers. Some people can find recommendation on the internet. But medical nutrition therapy, it means evidence-based approach on used in the nutrition care process of treating and managing chronic diseases, including obesity and diabetes. So that's the reason why we talk about a nutrition intervention or medical nutrition therapy instead using the term diet. On the other side, we heard about physical activity, and I will not repeat the same slides and presentation like Professor Milenkovic already had. But we know that physical activity can achieve the weight loss, but also can improve cardiovascular risk, and also can improve glycemia, lipid profile, blood pressure, and also may improve the cardiometabolic status. On the other side, when we talk about treatment, pharmacotherapy treatment of obesity, and we will have the complete new presentation on pharmacotherapy of obesity, but you can see it here. If we have people who are obese, and if they have prediabetes, diabetes, hypertension, or other metabolic diseases, and for example, if they have obstructive sleep apnea, polycystic ovarian syndrome, or PCOS, or something similar, the liraglutide is the first choice of drug in pharmacotherapy for obesity. The second line would be naltrexone, and the third one will be orlistat. If we don't have those comorbidities, we can argue what would be the first step, and maybe naltrexone would be the first choice, the second one liraglutide, and the third one orlistat, according to Canadian Obesity Association. And what is the most important thing? The most important thing is efficacy evaluation, because no drug can achieve the same results to every single person with obesity. And we know that even for any single drug, we do have non-responders. And doesn't have sense to give them a drug and I don't care what will happen with him. So intensive lifestyle intervention, intensive medical nutrition therapy, intensive physical activity consulting, and also pharmacotherapy if needed. And right now, it's very difficult to expect that with non-pharmacological measure, we will success without pharmacotherapy, especially with people with comorbidities. And of course, our goal is at least to achieve more than 5, or especially if we can, 10% of weight loss within approximately 1 year, and also the beneficial effect on other healthcare parameters like glycemia, lipid profile, arterial blood pressure. So just to prevent the prediabetes to become diabetes, and also to lower the incidence of type 2 diabetes, to improve NAFLD or MUFLD, however we call, to improve PCOS, and also to improve sleep apnea symptoms. And of course we have to consider cost and safety. On the other side, here are what we have. And you can see it here in different situations, and especially different metabolic disorders, we can use different drugs. And people who do have established cardiovascular disease or have very high cardiovascular risk, they should be treated by drugs with a confirmed beneficial cardiovascular effect. And in this moment, only liraglutide has, in the dose of 3.0 milligram, have a beneficial effect beside glycemia, beside blood pressure, and beside beneficial blood lipid control, also have beneficial effect on reducing the cardiovascular risk, and also reducing the non-alcoholic fatty liver disease. On the other side, we know that in this moment, European Medical Agency confirmed, and in this moment we have a status like this. So you can find in the European Union and also across the Europe orlistat, naltrexone, and liraglutide in dose of 3.0, and we know the indication and we know the dosing. Orlistat 3 times daily, naltrexone twice daily, both are oral, and we have liraglutide once daily injection. On the other side, here you can see the pharmacological options and also the effects on prediabetes, and you can see that orlistat had reduction of 37% and liraglutide 79% reduction in risk of development of type 2 diabetes over 3 years. On the other side, only the effect of PCOS liraglutide have, and also reduction of the effect of obstructive sleep apnea, also liraglutide as well. So from that perspective, we know that we have only 3 drugs in this moment in Europe, and in the judgment of European Medical Agency, we can argue later on regarding what's going on in FDA. So just to conclude the Canadian guidelines, they said ask for permission, assess their story, advise on management, agree on goals, and assist with drivers on barriers for treatment of obesity. Now I would briefly comment the UAE clinical practice recommendation, and they are similar. All guidelines are similar worldwide, but there are some differences between them, and guidelines from UAE are from 2018, and you can see it here. Here are available orlistat and liraglutide in 3.0 milligram, and pharmacotherapy is indicated for the people with BMI about 30 or with no comorbidities, or 27 plus with comorbidities. And it's very similar to other recommendations. And bariatric surgery is about 40 kilograms per square meter with no comorbidities, and 35 kilograms per square meter with comorbidities. On the other side, you can see it here. If you are obese, comprehensive lifestyle intervention, comorbidities, if yes, you have to consider pharmacotherapy about 27, or about 35, you should consider bariatric surgery. And the last one, which I would like to briefly comment, is ADA EISD consensus statement. It's very similar, also from 2018. We do have also in Europe medication for weight loss, and metabolic surgery is recommended treatment for people with diabetes and type 2 diabetes, and especially with comorbidities. And when we talk about pharmacotherapy session, you can see it here. BMI above 27, it's for pharmacotherapy, and about 30 also metabolic surgery is indicated. On the other side, if we have people who are only obese with no comorbidities, in that case, we can start with pharmacotherapy about 30. And if we have some comorbidities like type 2 diabetes, like cardiovascular disease or something else, 27 would be appropriate BMI for treatment. And metabolic surgery, I already mentioned, and I will not lose time for that. These are pharmacological options for weight management, and indications are the same. Here you can see it, what we have in the Europe and worldwide, and also what is missing here, because it's only approved by FDA, is semaglutide in dose of 2.4, and it's called it's registered in USA, but it's not registered in Europe and other countries, and it's called Wegovy 2.4. And in this moment we have liraglutide 3.0, which called Saxenda. For treatment of diabetes is Victoza 0.6 1.2 and 1.8 is Victoza, and 3.0 is Saxenda, and is treated by once daily. And the common side effects or side effects we can account on is gastrointestinal side effects. But if we titrate the dose of liraglutide to 3.0, we will not have those problems in huge numbers of people. And summary, and dear ladies and gentlemen, let me conclude the summary of recommendation. We know that no matter about the cause of obesity, the cornerstone of treatment of obesity is lifestyle intervention, medical nutrition therapy, physical activity consultation, and also overall lifestyle intervention per se. On the other side, somebody who has a BMI about 30 with no comorbidities or 27 with comorbidities should be treated by pharmacotherapy. In this moment we have 3 possibilities, 2 oral and 1 injectable, and the most successful according to trials are liraglutide in the dose of 3.0, and of course if we have a BMI above 40 with no comorbidities or 35 with cardiovascular or other comorbidities, we should consider bariatric surgery. And when we talk about inclusion of liraglutide, as I already told you, there are many different things and different aspects, and according to your guidelines, which are used in your region, you can see it here that liraglutide is useful for weight loss, for reduction of type 2 diabetes, also regression to normoglycemia, and also reduction in HbA1c, and it's good for weight loss maintenance. And to summarize, when we talk about obesity, we should consider about definition, we should consider the reasons for obesity, we should consider management, as I already mentioned, and also we should not avoid pharmacotherapy if needed, because today it's very difficult to lose weight because we are all eating too much. We don't have time to go to gym or going around with bicycle, and even right now we are sitting all day here, so it's not easy even for us as a physician and healthcare providers, and it's not easy neither for people with obesity.